Hello also to Zoom folks. Alrighty, I'm gonna go ahead and open up our schizophrenia lecture here. Alrighty. Okay. All right, so just a couple quick announcements. One is that I did in fact catch up on graded exam 2. I haven't started the media project yet because I only have like 4 turned in. So make sure you turn those in. The other announcement is to be thinking about your group project. Your group meeting should be done with me by the day of the academic symposium. So that's a couple weeks away. And then exam 3, I will get put up this week, so that y'all have a week to work on it. Before it's due, I'll try to do it today, honestly, so that you have that. And yeah, so we'll finish up with schizophrenia today. We'll start substance use disorders on Thursday. I will let you all know about the guest speaker. Unfortunately, what we were thinking of doing, like having someone talk about like PTSD specifically with a service dog, isn't quite going to happen, but there will be a veteran who's speaking with his service dog. And what we might end up going to during our class time is a lecture about how to be a puppy raiser. So I don't think anyone would be super sad about learning how to be a puppy raiser and meeting some puppies. So I will keep you informed as I look at those. Any logistical questions about anything going down for our class? We're getting near the end, y'all. All righty. And then hide them. And you might all be like, why do you turn them on then hide them? Well, if I do that, it will actually give me a transcript I can upload to YouTube for y'all. So, because YouTube used to do that and they don't anymore. Fun. Alrighty. So we talked about all the symptoms of schizophrenia last week. And now we're going to talk about some of the specifiers. So you can specify a whole bunch of different things about schizophrenia, just like you can for other disorders. So like, this is their first episode ever. They're currently in the midst of an acute episode. So this is their first, what's sometimes colloquially called psychotic break. And then acute means symptom criteria are fulfilled right now, basically. Then there's the first episode in part of remission. 3 extra chairs up here, and I'm not really sure why. And so this would be, there's an improvement after a previous episode, and it's maintained for a little bit, and the defining criteria for the disorder as a whole are only partially fulfilled. You can be in full remission. There's no disorder-specific symptoms present. Then you have the same thing, but for multiple episodes. Multiple means 2 or more. So multiple is basically just more than 1. So some people will be on their 2nd, some people will be on their 17th, right? And they would still be classified as multiple episodes. You can then have continuous. And this is where symptoms fulfilling the diagnostic criteria of the disorder are remaining for the majority of the illness course. So they are not going away. They are just, you've got these symptoms all the time. Maybe sometimes they're sub-threshold, but you're still meeting criteria. And then you can also have unspecified. Unspecified would typically be used only in like an emergency situation. So you go into the ER with a psychotic break because you have no idea what's going on, right? And they might give you schizophrenia unspecified and hope that a mental health professional will actually diagnose you properly later. And then there's with catatonia. And so with catatonia, we talked about some of these symptoms. You have to have 3 or more. I don't think I have them on here. I do not. So let me stick this back up here. But stupor, which is not responding to the environment. Catalepsy is that a posture held against gravity. Waxy flexibility would be where they would, like, again, bend like an action figure if you tried to manipulate their limbs. Sometimes you have mutism where they don't speak at all. Negativism is opposition to instructions or absolutely no response to instructions. Posturing, which is spontaneous or active maintenance of a posture against gravity. Mannerism, some sort of like caricature of normal human actions. Stereotypy would be repetitive, non-directed, non-goal directed movements. Then you can have agitation, grimacing, and then a couple of this disorganized symptoms we talked about last week. So echolalia, repeating speech-wise, echopraxia, repeating motions. So as I mentioned last week, it is possible to get a diagnosis when you haven't had symptoms of schizophrenia for 6 months yet. We don't just go like, come back when it's been 6 months, you'll be fine being completely psychotic and on a touch with reality. So this is called the schizophrenic spectrum. And the idea here is that disorders fall along a continuum, but they all have like a schizophrenic flavor, flair, commonality. So schizoaffective disorder is where you have symptoms of a mood disorder and schizophrenia that onset simultaneously. So a person may also meet criteria for mania and or depression along with schizophrenia simultaneously. These get specifiers as well. The specifier here would be bipolar type or depressive type. And there are 2 additional disorders along the schizophrenia spectrum that differ from schizophrenia only in terms of temporal criteria. So schizophreniform disorders, disorder is you've got a psychotic episode with all the features of schizophrenia, but it has not yet lasted 6 months. It's been more than a month, but not 6 months. And then if it keeps going to 6 months, then just like with acute stress disorder to PTSD at 1 month, the diagnosis would change to schizophrenia after 6 months with symptoms. And you specify whether it's with or without good prognostic features. So does it seem like this will be like a one-time thing for this person, or does it seem like this is not going to go very well? Brief psychotic disorder is where you have a psychotic episode with all the features of schizophrenia, but it lasts less than a month. People diagnosed with brief psychotic disorder will actually usually return to normal functioning. So unlike people diagnosed with schizophreniform disorder, the large majority of which will continue on to be diagnosed with schizophrenia. And so the reason brief psychotic disorder is distinct is because there are people who have these symptoms 1 month or less and never have them again. But there are people where brief psychotic disorder would then lead to schizophreniform disorder, which then might also lead to schizophrenia. Here, there are specifiers with or without a marked stressor in their lives. And there's also a postpartum onset. So yes, a lot of people don't realize, we think of just postpartum depression, but there are a whole host of postpartum disorders, including postpartum anxiety and postpartum psychosis. Delusional disorder is where you have non-bizarre delusions that last at least a month, at least once per day, and the person becomes delusional over an extended period of time, but they don't have other symptoms of schizophrenia. So they don't have the disorganized speech. They're not necessarily experiencing the negative symptoms, but maybe you have a delusion that someone who's a famous TikToker is infatuated with you. And if you only meet that person, you two would be together. There are a bunch of different specifiers for these. I'm not going to go into them in too much detail, but just share with you some of the ones you might enjoy. So the one example I just gave of someone being in love with you is the erotomatic type, where the central theme is another person is in love with the patient. And there's also a persecutory type, being conspired against, cheated, spied on, followed, poisoned, drugged, harassed, or obstructed. And there's also a jealous type, which is where you have delusions that your spouse or lover is unfaithful, like to the point of maybe even stalking them. All right, so we have a brief video about schizoaffective disorder here.
I believed for at least
And as per usual, when I'm in this room, I have to figure out who did what with the sound. Yeah, that looks good.
a month that I was dead. I was seeing things darting at my head, shadowy figures. I would see these full-fledged hallucinations.
All right, I'm
Hi, my name is
over.
I believed for at least a month that I was dead. I was seeing things darting at my head, shadowy figures. I would see these full-fledged hallucinations. Hi, my name is Esme, and this is how I live with schizoaffective disorder. My parents were not the kind of people who would ask me to go seek help. I had to go and seek out myself. I knew that something was wrong with my mind, or that something was wrong other than just classic teenage angst. I was diagnosed with clinical depression and anxiety pretty quickly at 15 or 16. About 2 or 3 years later, my symptoms started to change. I started having symptoms of mania. As a freshman in college, I was diagnosed with bipolar disorder. I was involuntarily hospitalized. It was terrifying. A couple of years into my time at Stanford, I began to experience psychotic symptoms, hallucinations that would cause me to kind of duck or dodge. I would think that my loved ones were replaced by doubles. The scariest thing to me was the stuff that I couldn't cover up. I could just imagine the people all around me looking and thinking, what is wrong with that person? They look insane. I had an education in psychology. I really thought this might be schizoaffective disorder. You have your psychotic symptoms in between the mood episodes. I brought this up to my psychiatrist. She didn't want to kind of put that stigma of a different diagnosis onto me. So we kind of were in a holding pattern for about 8 years. People don't really have an idea of what schizophrenia or the schizophrenias are. It's this idea of split mind or multiple personalities. I wrote the book, The Collected Schizophrenias, because I felt that so many of the books that currently exist are not written from the perspective of people who are actually living with the disorder. What I needed to hear when I was diagnosed were the voices of people like me. Listen to your gut feeling. Your gut feeling knows a lot more than you think. And your gut feeling has your best interests at heart. Not only that, but you can survive this, and you will survive this. And a lot of good things will happen to you if you can just stick this out and keep going.
So I really like that one because it talks about something we talked about at the beginning of the semester in terms of stigmatization of diagnosis, right? And like here, it was actually harmful that her psychiatrist was like, I don't want to stigmatize you. I don't want to put that label on you. But it meant for 8 years, she might not have been getting the full treatment she needed, right? That's problematic in my mind. All right, so some demographics. And if you don't mind flicking the light back on, thanks. Just because it's really dark in here today. So we know that certain people are at higher risk of schizophrenia. So for example, people in lower socioeconomic groups. Unfortunately, because of our society and how things work in the States in particular, a lot of people in the lower socioeconomic groups are people of color, in particular African-American folks. Urban dwellers, so it's typically associated with poverty. We know that poverty causes a lot of stress. We know that stress can bring out symptoms of schizophrenia. Also, if you have a biological relative with any kind of schizophrenic spectrum disorder, any of the ones we just named, you're at higher risk for developing a disorder as well, whether it's full-blown schizophrenia or one of the other ones. In particular, if your parent or sibling has a schizophrenic spectrum disorder. There are some folks who seem to be at lower risk. And there's a study that shows that later born siblings are at lower risk for development of schizophrenia or psychotic disorders. I don't know why, other than oftentimes earlier born siblings have more responsibility and stress in the family. But that one befuddles me. All right. So there are different phases of the disorder. Prodromal is the first stage where the symptoms are just starting to develop. Active is the second stage where you have active symptoms, particularly involving psychotic symptoms. And so this would be that acute that we talked about during specifiers. And then residual, and this is that third phase where the individual is no longer psychotic, but they still might show disorganization, delusions. Well, delusions are psychotic, sorry. But they might show the negative symptoms as well. The onset is typically in your early to late 20s. It's rare to begin before adolescence, but as we mentioned in passing last week, it can happen to individuals as young as 5 years of age. Both genders or all genders are equally affected, but the age of onset is slightly later for women, and that women tend to have higher pre-morbid functioning and fewer negative symptoms. So women who are diagnosed with schizophrenia are typically, again, like my client I described last week, they're doing great, they might have their own job, be living independently, and then this hits. All right, so let's talk about the biological perspective. I'm just gonna throw these all up here. All right. So as with other disorders, we're talking about identifying abnormalities in the brain that might be related to the development or the recurrence of schizophrenic symptoms. So in terms of brain function abnormalities, it seems that what we see is hypofrontality, which is a decrease in activity in that prefrontal cortex, the one right behind your forehead, which is the one that allows us to do things like inhibit things, organize, things along those lines. It's also related to personality and emotion. And it's thought that hypofrontality may be associated with negative symptoms, such as a lack of emotion, the apathy, the lack of motivation. There might be some neurotransmitter abnormality. There's a dopamine hypothesis that argues that there's excess dopamine in people with schizophrenia, and that's what actually causes, for sure, psychotic symptoms, but maybe all the positive symptoms, including the disorganized one. And this is similar to what we'll talk about when we talk about stimulant drugs, starting on Thursday. Stimulants increase the amount of dopamine in the brain. So if you take too many stimulants like methamphetamine or even caffeine, it can actually produce symptoms that look like psychosis. Now, in terms of structural abnormalities within the brains of people with schizophrenia differ than the brains of people without it. So one of the earliest and most robust findings here is that individuals with schizophrenia have enlarged lateral ventricles. So ventricles are the fluid-filled cavities in your brain. If you've ever seen a brain scan, they're the two sort of like curve-shaped things that everybody has. They help with things like balance, regulation of the cerebral spinal fluid, things along those lines. And so people in schizophrenia have these enlarged ventricles. So to have larger ventricles, that means you have less or smaller brain tissue. And the thought is this might be due to reduced blood flow to the brain, and that this loss of brain tissue contributes to those negative symptoms of schizophrenia. People with schizophrenia have been shown to have smaller temporal lobes. Temporal lobes are the ones that are like right here above your ears, and abnormalities in both their frontal and parietal lobes. Parietal lobes are sort of more here. And also some of the subcortical structures like the corpus callosum, which is the connection between the two sides of the brain, and the thalamus seem to also have some abnormalities as well. So how does this translate? Here we go. So this shows the ventricles. So here are the normal ventricles, and then here are the enlarged ventricles for someone with schizophrenia. You can see much more fluid, right? And then that translates to less brain matter. And then this shows you some of those areas of the brain that might be affected. All right, so what does this actually mean? What do these things translate into? And again, I'm just going to try to click everything up so I don't have to click in between each word. So neuropsychological deficits, these contribute to the impairment in cognitive functioning. So people with schizophrenia have been shown to have reduced cognitive abilities, including verbal fluency issues, issues with learning, memory, attention, and even their psychomotor abilities. They have impaired sensory gating, which means it's difficult for them to process sensory input. Input. I don't even know what input would be. So they can just feel flooded with stimulation at times. In terms of what might be some biological predisposing causes here, it appears that the brain abnormalities present in schizophrenia are apparent early in life before the disorder appears. So that speaks more to the possible genetic component, right? That this exists maybe from birth. And so it's not, for a long time, people thought there was like some sort of degenerative process in the brain, and it does not quite seem to be that. Schizotaxia is the potential for developing schizophrenia. And we can look at this a couple ways. The abnormal brain structures we just talked about, the abnormalities in cognitive or neuropsychological functioning, and then eye tracking issues. So eye tracking is your ability, like when the doctor has you follow a light or follow their finger, there's actually deficits in that in people with schizophrenia or schizotaxia even. So before the schizophrenic symptoms appear. There also are some suggestions there might be some environmental causes. So over 250 studies in more than 39 countries have found that babies born in winter or spring have higher chances of developing schizophrenia. Now, why the heck is that? Everyone was going to, I'm sure in here is like, oh, well, what it is because the mother would then be pregnant in winter, the baby would then have the potential to be exposed to more viruses that could, in theory, influence brain development. Since we know cold and flu season tends to be in the winter. Now, in terms of pregnancy and birth complications, if the baby does not receive enough oxygen during birth, there seems to be some issues there. It also may be linked to maternal drug use during pregnancy. And then viruses during infancy have also been shown to be related to schizophrenia in adulthood. And this is yet another reason why it is important to vaccinate your children. In terms of genetics, which I keep circling back to, it really does seem like it's inherited, but that you need environmental triggers to actually have it fully appear. So this is that diathesis stress model we talked about at the beginning of the semester, and that there has to be some sort of genetic predisposition or diathesis. And then there's a stressor in the environment that causes the psychotic break or causes the symptoms to develop. All right, so we know this isn't great. We know there seems to be a biological component. How do we treat it? We got a lot of antipsychotics, which is good because we need that. So the first generation antipsychotics were not great in terms of side effects. They would reduce the positive symptoms, but not treat the negative symptoms. Severe side effects can include tardive dyskinesia, which is where people would have involuntary movements of their tongue, their jaw, their trunk, or other extremities. And then you could have a rare but fatal condition called neuroleptic malignant syndrome, characterized by muscle rigidity and elevated body temperature. Not great, right? There are also issues with first generation antipsychotics in terms of brain fog for people, feeling like they couldn't be themselves. And there are issues with all antipsychotics with things like weight gain. So I think I mentioned last week, my one client who gained about 80 pounds after she started antipsychotics. So this morning in my internship class, we were talking about schizophrenia and we watched Part of a Beautiful Mind, which is a great movie if you haven't seen it. And John Nash, the main character, real guy, he was a Nobel Prize winning economist, and he felt like on his medications for schizophrenia, he couldn't do his economics. He couldn't think, he couldn't like solve mathematical equations. So he stopped taking it. And then obviously his symptoms came back. The second generation antipsychotics will treat both positive and negative symptoms. But patients are still moderately to severely affected by their symptoms in general. But they do have less side effects. What typically happens for people with severe mental illness, whether it's schizophrenia, whether it is like severe bipolar disorder, one of the personality disorders, is people often end up on a cocktail of medications where they might also be taking like an antidepressant to treat the negative symptoms, things along those lines. Now, there are some cutting edge biological treatments. So for the example, you could identify at-risk individuals for schizophrenia and treat and try to prevent the disorder before it develops using antipsychotics. And so again, even though the person is not necessarily diagnosable at that point in time, this has been shown to diminish some of the symptoms they may be experiencing. So some of those negative symptoms appear before a positive symptom ever appears. So they might have the flat affect, the lack of motivation. Yeah, and I had that up there. Okay, here is another video. And David, if you don't mind killing the lights.
I started hearing voices, and it was not unfamiliar voices. It was mostly characterized voices of my friends. I started getting really paranoid because obviously the voices were saying things that disturbed me. Really and truly, my first break came about when I was
And I'll just stop real quick here to say that this idea of using peer counselors is really gaining momentum within the mental health movement. The idea that people who have been through what you've been through can relate in a different way, even than someone who studied it, right? And so there's a lot of like trying to empower and advocate for these folks.
17 years old.
My son has been an adventure. You never know ahead of time where the challenges are going to be in life.
I'd been trying to get people to realize that there was something going on with me that wasn't quite normal, and wound up getting into trouble. I was checked into an adolescent rehab center, so to speak, and was put on medication there, and that was when I received my first diagnosis. He diagnosed me with paranoid schizophrenia. Stopped taking my medication after about a year. It didn't take very long for my symptoms to start returning. I thought, if I don't do something, to get some help, I'm gonna end up dying or something. So I walked past a fire truck. I saw, an axe on it, and I thought, well, I'll just take that axe off that truck, and someone will have to notice me then. I didn't realize it then, but that was the beginning of several years of being in an institution.
It's not a book written to tell you how and what to do as a dad or a mom. For me, the lesson I have learned is that I don't have all the answers.
Sharing my story is a privilege, and it's important for me because it reinforces my recovery, my life. It helps me stand on my own 2 feet every time I share it.
So again, here you can see someone who medication worked for a while, but then it stopped working. That can happen. Sometimes you need to change the medication cocktail. Sometimes you need to seek out an additional type of therapy. So, adding these things together can be really helpful. So again, I'm gonna pull up the cognitive perspective here. So one of the things that the cognitive perspective emphasizes in schizophrenia is the idea that there are these abnormal attentional processes that we talked about in the biological section, right? The idea that people get like overwhelmed by sensory stimuli, feel flooded with it, right? So there seems to be this over attention to irrelevant stimuli. So people with schizophrenia seem to be unable to screen out the irrelevant stimuli. They have difficulties coping with stress because they're flooded with so much information as a result. And they have delusions when they try to explain their odd subjective experiences to someone else or to themselves. So someone with schizophrenia, rather than focusing on like my voice, might be focusing instead on like the hum of the projector, right? Because that feels just as important. And then negative symptoms might be an under attention to important stimuli. The idea here is that people with schizophrenia who have negative symptoms don't have a normal orient or attentional response, meaning they do not exhibit physical changes associated with sharpening attention. So one of the things that we know is associated with sharpening attention is like eye movement to look at it, pupil dilation. And when they've done experiments with folks with schizophrenia, they don't actually show those. And this can lead to the withdrawal and the apathy. Now, how do we do cognitive treatment? Well, a couple different ways. One is cognitive rehabilitation, which are you just try to train the person to refocus their attention. So decrease both the over attention to irrelevant stimuli and the under attention to relevant stimuli. And then the big thing that's happened within cognitive therapy, and a lot of work has been done on this in the past 10, 15 years, is cognitive restructuring and sort of treating the delusional beliefs like any other negative automatic thought. So therapists emphasize that normal but exaggerated cognitive processes and emotional problems are underlying the symptoms. So it may be they're experiencing things very similar to our clients with depression or an eating disorder, but it's just they have this biological predisposition to, psychosis. So for example, persecutory delusions and hallucinations are believed to be exaggerations of expectable reactions to fear and mistreatment that individuals with schizophrenia often experience in their daily life, right? People are scared by them, you sidestep them, right? Even as a person trained in psychology, if someone comes up to me and they're talking to themselves, right? I'm not qualified in that moment to be treating them on the street. One of my friends on the internship would just say in their head to yourself, mental health, mental health, mental health, to just remind yourself like this is a person struggling with mental health issues. They're not actually dangerous. All right, and this one's short, so we don't need to turn the light off, but this is Aaron Beck talking about how to use cognitive restructuring in schizophrenia.
When you're dealing with patients with schizophrenia, say the chronic people who have neurocognitive problems in attention and memory and so on, you have to do the cognitive restructuring in a very subtle way. And in fact, it's so subtle that nobody can recognize it except yourself. So one patient that my group was working with is a patient who'd been in the hospital for something like 10 years, and he was always behaving in a really negative way. And his most latest problem was that he was running around nude, and they'd force him to put his clothes on and take them off again. He was causing a big problem. So our therapist then tried to engage the patient, he'd been fairly non-communicative up until then. So he tried to engage him, and he said, oh, I guess one thing is the patient liked music. And so he played some music, and then he would ask the patient if he could recognize different piece of music, and then he played some video games with him. Then after he had formed this relationship with him, he asked him, what would you really, when you were growing up, what do you really want to do more than anything else? And you never ask these patients, what are your goals? Because they either come out with stereotyped things or they think you're trying to push them out of the hospital. So he said, you know, what I really wanted to do was to be an auto mechanic. I really wanted to be a machinist or an auto mechanic. And then he started to get enthused, and he talked more in the next 15, 20 minutes than he did in his entire stay in the hospital. And the therapist got him to describe what he would do as an auto mechanic. And he was just going along saying how great it would be putting the grease in and turning the screws and fixing the carburetor. And then all of a sudden he stopped. He says, you know, I won't be able to do it. And the therapist said, well, why is that? And he says, well, you know, there's these little tiny screws, and you have to use a tiny screwdriver. And I won't be able to see it. So the therapist said, well, when did you have your eyes tested last? And the patient said, well, I never had my eyes tested. So he had his eyes tested, and he got eyeglasses, and then he knew he'd be able to do the job. And from there on, it was a straight line till he was able to get discharged from the hospital. So where's the cognitive formulation come in? The cognitive formulation was that this person felt defeated. He felt that he wasn't able to do anything. He felt ostracized from society. And so his behavior was sort of defiant. It's just this way of getting back at the ward personnel who were giving him, you know, trying to force him to do things, take medicine and so on. So his nakedness was the defiant part. But when he could think of something and get supported in this, to something that would give him a sense of efficacy and self-confidence and achievement, then the defiant behavior then dropped off, and he put his entire focus on that. So the similarity is trying to formulate what is driving the behavior, and once you've made the formulation, then you do the therapy.
And Beck spent most of his 90s until he just got a little too frail, but studying this. I mean, the man did not understand the word retirement. He was, you know, I saw him, let's see, when he turned 97 at APA, they zoomed him in, and he was talking about doing this research, and the other guy who was leading it from our side said, like, you know, when are you going to retire? And he said, what's that? You know, it's just like he had these ideas in his head and he wanted to get it done before he passed away. And unfortunately, he passed away, I believe, at 99. But obviously made a bunch of contributions to the field of psychology, and in particular to treatment, and the idea that, like, we can treat people with schizophrenia essentially like we treat any other client was revolutionary when we started talking about it. But he believed it because he believed in the power of the cognitive model. Now, from the behavioral perspective, behaviorists are going to focus on the learning and the development. They are going to have argued that the reinforcement of abnormal responses, so they might get more attention if they're engaging in disorganized speech. can contribute to the abnormal behaviors of people who are schizophrenic through principles of operant conditioning, similar to a kid acting out with ADHD can be positively reinforced, even if they're getting yelled at, because they're still getting attention, right? So given attention for abnormal behavior, that behavior will continue in order to get that attention, because that attention in and of itself is reinforcing. In terms of behavioral interventions, these two are going to be based on operant conditioning principles, where you want to try to reduce the inappropriate behaviors, like walking around the ward naked, right? And increase the desired behaviors. So one of the ways they do this, particularly in inpatient settings, is what are called token economies. And in token economies, clients who engage in the desired behaviors can earn coin-like tokens that can be exchanged for privileges such as watching TV or having extra snacks. And then again, the reason that we do this in inpatient facilities is that the client can be consistently rewarded for their behavior. We also might focus in on social skills training. Some people with schizophrenia might not realize that the behaviors they're engaging in are inappropriate interpersonally. Like, to them, it just makes sense. And so you would sort of give them training on here's how you interact with a person to not freak them out, basically. And this has been shown to improve clients' social and interpersonal functioning. Now, family systems theory becomes very important here, just like in anorexia, because the family environment is implicated in people with schizophrenia. So oftentimes these folks are in an overly hostile, confusing, or pathological family environment. These environments are believed to possibly contribute to the development or maintenance of schizophrenia. They'll have what are called double-bind communications within their families. This is when they're given contradictory messages, particularly from whoever their caregiver is, whether that's a parent or some other person. So be independent, but also never leave me, which put the child in a no-win situation in which they don't know what to do to make that caregiver happy. And that can lead to cognitive confusion and emotional paralysis. And in someone who already has the biological propensity for this disorder, that is going to just spiral. Expressed emotion is another family issue that we see within schizophrenia. This is where there's high levels of criticism and over-involvement among family members. In a study done by Linzen et al. Back in the 90s, it was found that there are high levels of expressed emotion in families of individuals with schizophrenia. So again, expressed emotion here being high levels of criticism, high levels of over-involvement in each other's lives. And when those levels of expressed emotion decrease, the functioning of the person with schizophrenia improves. Or when those levels of expressed emotion increase, that's when people with schizophrenia tend to relapse. Now, in terms of family systems interventions, those are really, in these cases, going to focus in on hostile, confusing family environments, and also that expressed emotion. So kind of almost like social skills training for the family, right? That could be part of it. Here's how you interact with somebody. Now, in terms of sociocultural theory and interventions here, this theory is going to focus on the larger social and institutional forces that may play a role in the development and treatment of the disorder. Sociocultural researchers have found, as we mentioned previously, that people with low SES, people who live in urban settings, have higher rates of schizophrenia. So it's believed that urban poverty in particular may contribute here. The medical establishment itself is also thought to contribute to the ongoing pathology suffered by people with schizophrenia. Dehumanizing treatment of patients with schizophrenia in medical and sociocultural institutions are believed to contribute to the patient's symptomatic behavior. If you're sort of treated as someone that's crazy, you might be more likely to act like you're crazy. So what do we do in terms of interventions there? Milieu treatment is an institutional treatment philosophy in which patients take active responsibility for decisions about the management of their environment and their therapy. This is an effort to reduce that dehumanization that people with schizophrenia experience that occurs particularly in some medical and institutional settings. Now, assertive community treatments are going to offer frequent and coordinated contact with a wide variety of professionals in an effort to decrease relapses and rehospitalizations. So the idea is, okay, when you're get out of the hospital, we're not just going to kind of like leave you to the wolves. We are going to put a whole treatment team in place that's going to check up on you and make sure you're getting the care that you need. So some summaries here. Schizophrenia includes a spectrum of cognitive, emotional, and behavioral dysfunction. Again, these can be positive, negative, and disorganized. This should say DSM-5 and DSM-5R. We got some subtypes, we got some specifiers. There are other disorders that include psychotic features. In terms of causative factors, it certainly seems like socioeconomic stress, but in particular, genetics and biological things are implicated here. And unfortunately, with schizophrenia, as we talked about when we talked about downward drift, successful treatment rarely includes complete recovery. These folks can learn to function to some degree, but for a lot of folks, it just they won't ever quite get back to where they were before their break. And again, that can be quite sad. All right, we're going to end a little early today. Just because I powered through that and probably didn't need to talk as fast as I was talking, so apologies. Thursday we're going to start talking about substance use disorders. I know for some people, especially if you have a family history of that can be a little difficult to hear. So I'm just giving y'all the heads up about that I try to say fairly clinical when I'm talking about that.